Good evening, everyone. Welcome back and thank you for joining our online CME live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy and today we have Dr. Chong, our resident interventional cardiologist and physician, to update us on hypertension management in COVID-19 pandemic. Before we start, allow me to share a little on Dr. Chu's background. Dr. Chong obtained his medical degree from Dalhousie University, Canada. He has vast experience in internal medicine. He is accredited as a member of Royal College of Physicians, Glasgow, UK. He further pursued his subspecialty training in general cardiology, cardiac imaging and interventional cardiology. As interventional cardiologist, Dr. Chu is also qualified in diagnostic imaging, including cardiac echocardiography, CT coronary angiography, and non-invasive stress testing. His area of specialty includes invasive coronary angiography, complex coronary angioplasty, device implantation, invasive cardiac catheterization, congenital heart disease, and valvuloplasty. He is actively involved in multiple researches and publications. He has special interest in valvular heart disease, cardiac rehab, and myocardial infection. So if you have any question for Dr. Chu, please WhatsApp your question to the phone number as stated below, and Dr. Chu will try to answer your question towards the end of our session. So I will pass this session now to Dr. Chu. Good evening, Dr. Chu.
Thank you, Lucy, for your kind introduction. Today we're going to talk about hypertension. So first of all, thank you to Gleneagles for hosting me and having this webinar. So our focus of discussion today is mainly about hypertension. I'm sure being in your practice, day-to-day practice, you come across a lot of patients with hypertension, and it become a question since Lancet published a paper about should we change the how we manage hypertension, and it become a question. Some of the patients will come to you and ask you about the medication that he's on, specifically talking about ACE inhibitors and ARB, whether they should change the treatment or not. So without further ado, let's give me 30 minutes. We'll talk about do we actually need to change the way we manage hypertension in this era of COVID-19. So this is my disclosure. Okay. So today we're going to talk about coronavirus and what is ACE2 in respects to coronavirus, and the conundrum behind using ACE or ARB in the era when there is COVID infection. What about the position statement from guidelines over the world? Do we actually need to change? With all this knowledge, how are we going to change the way we manage the patient? So I think these cartoons sort of reminds you of day-to-day practice. So what is coronavirus? So coronavirus are a group of viruses that infects the respiratory system and cause a variety of symptoms, including cough, runny nose, sore throat, and occasionally a fever. Most coronavirus infect only animals, but there are 7 strains now known to cause human infection. Many adults have been infected by coronavirus at least once in their lifetime. The novel coronavirus 2019, also known as COVID-19, is a new strain of virus. It was first reported in December 2019 in Wuhan, China, and therefore humans have never been exposed to this virus before. The novelty of this virus makes it particularly impactful because none of us have been exposed to it and none of us have any immunity against this virus. To date, around the world, there are close to 10 million confirmed cases. About 5 million have recovered, and the death tolls around the world is close to 500,000. In Malaysia, we have close to 8,600 patients confirmed case and about 8,271 recovered. The death toll in Malaysia ranging about 120 patients. When you look at the worldwide statistic, the mortality rates range about 5%, whereas in Malaysia, we are doing a little bit better. It's close to about 1.4%. Now, the symptoms of COVID-19 is very variable. It can range from asymptomatic, just a normal day-to-day, a little bit cough, to death. Age seems to play a significant role in fatality. For example, if you split things out of age, when you split their age, you will notice that the fatality rate is actually relatively low when you're below 60 years of age. There were no cases of death so far reported in children aged less than 9 years old or younger. But you can see the mortality rates actually goes up. When you're more than, in the China cohort, when you're more than 60 years of age, the mortality rate is approximately 6.4%. However, when you look at the Italian cohort, when you're 60 to 70 years of age, your mortality rate is about 3.5%. And if you're more than 80 years of age, the mortality rate actually goes up to close to 20%. Yeah? All right. Similarly, the fatality rate or the mortality rate is higher with other comorbidities. Yeah? Comorbidities like hypertension, diabetes, patient with cancer, patient with chronic respiratory condition, they have higher chance of dying. When you look at the diagram here, if you have cardiovascular disease, the mortality rate actually goes up to near to 10%. When you look at the cohort, the Italian cohort, coronavirus mainly affects the male gender and old age. When you look at the cohort from the Italy, the prevalence of hypertension in those infected patients is close to about 73%. And although the clinical manifestation of COVID-19 are dominated by respiratory symptoms, some patients may have severe cardiovascular damage. Some patients with underlying cardiovascular diseases might have increased risk of death. When you look at the China cohort in Wuhan, myocardial injury associated with SARS-CoV occurred in about 5 out of 41 patients diagnosed with coronavirus in Wuhan. Mainly they manifest as increase in high sensitive cardiac troponin level. Among the confirmed case of COVID-19 infections reported by the National Health Commission of China, some of the patients went to see a doctor because of cardiovascular symptoms. The most common complaint is actually palpitation and chest tightness. Yeah? So that's something that you should consider when a patient step into your clinic and talk about palpitation. You never know, they may be harvesting coronavirus as well. So among the people who died from coronavirus, 11%, about 12% of the patient without underlying cardiovascular disease has substantial cardiac damage. And this is mainly reported as a raise in cardiac enzyme, or the patient have cardiac arrest during hospitalization. Now there is an interesting data published in Wuhan that close to 5.7% of patients develop ischemic stroke. So it's quite a large number compared to the New York study. About 0.9% patients actually develop ischemic stroke without any prior cardiovascular risk. So how does coronavirus or COVID-19 act? So the pathophysiology of the coronavirus infection involves the virus binding to the host receptor called angiotensin converting enzyme 2, ACE2. Okay. ACE2 receptor is found in your kidney, your lungs, your heart, and the vascular system. ACE2 is one of the key members of renin-angiotensin system, an RS system. So the distribution of the receptor probably can explain the variability of the symptoms that the patient might have. When the virus affects your lungs, the patient can develop acute lung injury sometimes they can have inflammatory, this is because of inflammatory response to cytokine storm. Okay, so therefore probably that's the reason some of these patients respond very well with steroids. If the virus affects the heart, the patient can present with myocarditis. Maybe they can manifest as palpitation, chest pain, or probably heart failure. If the virus affects your microvascular system, and there's a possibility that can destabilize the plaque and cause the patient to have large vessel stroke or myocardial infarction. Some of these patients, when they are ill, they develop acute kidney injury. That is direct. This is because of the virus itself. Now, the clinical response depends on the dysregulation of the RAS and the ACE2 receptor, and the number of targets that is variable between individual to individual. That's probably explain why some of the patients are more severe compared to the rest. So, to understand more about what is ACE2, unfortunately we need to review your RAS pathway. This is probably very familiar to most of you guys who so your RAS pathway is a closed loop of feedback mechanism that help maintain renal blood perfusion. Whenever there is a systemic hypotension or renal artery stenosis, there will be a drop in the blood pressure. The perfusion to the kidney will be affected. That will cause the kidney to excrete renin. Okay, the renin will change the angiotensin to angiotensin 1. Okay, angiotensin 1 will be changed to angiotensin 2 via the ACE angiotensin converting enzyme that is excreted from your lungs. Your angiotensin 2 is a very powerful vasoconstrictor. At the same time, it causes vasoconstriction. At the same time, it also stimulates the adrenal gland to produce mineralocorticoids. A well-known mineralocorticoid is our aldosterone. Okay, this aldosterone is very important. The aldosterone will increase the water and salt reabsorption. Therefore, with all these mechanisms, it will normalize the blood pressure and improve the renal perfusion. So this cycle will go on and on until our blood pressure is normalized. So our ACE affects here, our ACE inhibitor actually block here, and our ARB, angiotensin receptor blocker, actually block here. So just to revise, our hormones consist of angiotensinogen, angiotensin 1, angiotensin 2, and your angiotensin 1-7. Our enzyme include your renin, ACE, ACE2. Our medication that's involved in this pathway will be your ACE inhibitor and ARB. Okay. This is the picture to show how the coronavirus or SARS-CoV looks like. Basically, it's a spherical virus. Okay. You will see there's a lot of spikes, glycoprotein on the surface of the virus, and this is the main causation or the cause, the infectivity of this virus. The virus looks like crown, therefore we call it coronavirus, hence the name coronavirus. Yeah? So how do coronavirus cause infection? Basically, when you look at this diagram, when the spike protein binds to the ACE receptor, with the help of transmembrane serine protease, this ACE2 is cleaved off, and this activates the spike protein and to facilitate the entry of the virus into the cell. So this ACE2 receptor is very important in terms of the infection. The entry of the virus into the cell will cause our ribosome in the cytokine and the cytoplasm to create more copy of the virus, and therefore establishing a reproductive system. The new virus will be budded out from the cells to cause more infection and to cause more to spread the virus from one to the other patient. Remember, the aim of the virus is to reproduce, and infect as much host as possible to ensure its existence. Okay, with the virus attaching to the ACE receptor, this will reduce the number of ACE2 receptor that is found on the surface of the cells. At the same time, it attenuated its function. Now, how does that cause problem? Now we know that ACE2 is responsible to convert your angiotensin 2 to angiotensin 1-7. Now, angiotensin 1-7 is equivalent to the good guys, that counter-check the balance between angiotensin 2 and because of the vascular constriction and inflammatory response. With the viral infection occupying the surface of the ACE2, it further downregulates, making the ACE2 receptor least available for the conversion of angiotensin 2 to angiotensin 1-7. Okay. Now, when you look at this, angiotensin 2 increase your blood pressure, it causes inflammation, and it's atherogenic, so it's a bad guy. At the same time, angiotensin 1-7 it lower your blood pressure, and it behave like an anti-inflammatory and antioxidant effects. So it's sort of a balance between causing more inflammation and to reduce the inflammation. So the balance is very important to keep the inflammation at check. So possible inactivation of the ACE2 protein bound to this virus. If the virus is occupied the ACE2 receptor, it increases the vascular inflammation. It causes local arterial thrombosis. Therefore, it may explain why the stroke and digital ischemia risks are higher in patients with COVID-19. So again, this diagram illustrates the same thing. Yeah? When you have renin, it converts the angiotensin 2 to angiotensin 1 and angiotensin 1 to angiotensin 2 by the action of ACE. Okay. Now, ACE2 is responsible to convert your angiotensin 2 to angiotensin 1-7. So again, this is the good guy, so they protect your vascular territory to prevent inflammation from happening. So the binding of the spike protein on ACE2 and the subsequent downregulation of this receptor contribute to lung injury during SARS. Although it seems like counterintuitive that receptor downregulation would increase the pathology, it has been shown that ACE2 can protect against the acute lung injury. The downregulation of ACE2 results in excessive production of angiotensin 2 by the related enzyme ACE, and it has been suggested that simultaneous stimulation of the angiotensin 2 receptor increased pulmonary vascular permeability, thus potentially explain the increased lung pathology when the expression of the ACE2 is decreased. Okay, so the conundrum lies whether ACE2 is actually beneficial or detrimental. And there are actually two schools of thoughts. People concerned about the RAS blockage. If you block the RAS inhibitor, is it going to cause more harm? Again, if you block the RAS inhibitor, is it going to cause more good? So which one is right? Okay. What are some concerns that blocking the RAS inhibition in COVID-19? So again, you go back to this diagram. If you give the patient ACE, okay, you block the conversion of angiotensin 1 to angiotensin 2, and you give the patient angiotensin receptor, that may cause our ACE2 receptor to increase. Now, when you have abundant ACE2 receptor, it may potentially benefit the virus entry, because remember the virus attached to your ACE2 receptor. If you have more virus enter the cells, there will be the possibility of fulminant COVID infection will be higher. So that is the main concern. So what is the available data so far? Some of the rat study actually shows ACE inhibitor and NLRP actually upregulate ACE2 receptor. On the other hand, some of the animal models, they actually show there is no increase in ACE2 receptor in patients that has been given ACE inhibition and ARB. Similarly, none of the study did show any association between RAS blockage and the level of ACE2. So in human study, we actually don't see the effect that if you give ACE inhibition and ARB, it can change the level of ACE2 level in your body. So what about the potential benefit regarding ACE2 or ARB RAS inhibition? Again, you look at this diagram. If you block the ACE and you block the ARB, there will be increase in your ACE2 receptor. However, the increase in ACE2 receptor does convert your angiotensin 2 to your angiotensin 1/7. Remember, angiotensin 1/7 are the good guys that actually counter-check the inflammatory response of this angiotensin 2. So it's believed that if you give more ACE2 receptor, there's a possibility it may be a protective. So what are the evidence that actually support the idea that increase in ACE2 receptor is protective against lung injury? So one study that actually found mice treated with ARB, and then unfortunately all these mice are treated with acid aspiration. They found that if you treat them with ARB and ACE inhibitor, the chances of lung inflammation is actually lower. Another study actually showed that recombination human ACE2, meaning that you actually give a recombinant human ACE2 receptor, direct inject into the mice, they actually can prevent them from getting lung injury in those mouse that have ACE2 knockout. Okay. Some small studies in patients with COVID-19 also appeared to have higher level of angiotensin 2, which in turn correlate with the total viral load. So meaning that, when you look at those patients who actually have infection COVID-19, the angiotensin 2 level in the blood is actually higher than normal people. So with that in mind, should you reduce the angiotensin 2 by increasing your amount of ACE2 receptor? So there's a lot of questions. Still leave us with a lot of questions. The experimental animal models have shown a mixed finding. Basically, some say yes, some say no. Basically, further clinical studies are required. The understanding of this COVID-19 is still evolving, and it's probably too early to tell whether ACE or ARB treatment does affect the way we manage the severity of the COVID-19. Okay. So, but however, we know that maintaining RAS blockage is actually very important in terms of active myocardial injury, myocardial stress, and cardiomyopathy. The RAS inhibition has been well established in protecting the myocardium from inflammations and myocardial stress. So with all these facts, what do the guideline actually says? So this is probably the most important slides that you need to remember. So patients who are actually taking ACE inhibitor or ARB are not advised to change the therapy unless advised to do so by the physician. When you look at the statement, all the international society, for example, European Society of Hypertension, European Society of Cardiology, Canadian guidelines, the UK guidelines, they all concur that it is strongly encouraged to continue the ACE and ARB treatment due to the lack of evidence that to support that the use of these drugs is actually detrimental to COVID-19 infection. Same goes to the American guidelines, the Spanish guidelines, the Australian. They all support the continuation of the therapy. If you wanted to change the medication, change the way we manage the hypertension, you must consider withdrawing ACE and ARB blockage. What is the complication of withdrawing this, of stopping all this treatment? Okay, so you must understand RAS inhibition is still the first line recommendation in most of the hypertension. The benefit of stopping this therapy is still unknown. When you look at the NICE guideline, you can see step 1, step 2, and step 3, ACE and ARB treatment is recommended in all these patients. Similar goes to the patient who had comorbidities besides hypertension. We are talking about a patient with left ventricular hypertrophy, a patient with asymptomatic arteriosclerosis, microalbuminuria, renal dysfunction. We will see benefit of therapy in this kind of patients with regards to ACE and ARB treatment. Okay, so even the Malaysian guidelines, ACE and ARB is used throughout with patients with hypertension with other comorbidities. So what is next? We know that only about 37% of Malaysians actually achieve blood pressure control of less than 140/90 while on treatment. I want to show this slide is from our Malaysian CPG. Again, every patient, our target is still for normal patient that without any comorbidities. Our target for hypertension is still 140/90. For diabetic patient, our target is 140/80. If the patient with end organ damage, for example, ischemic heart disease, arteriosclerosis, or renal problem, our target should be lower, 130/80. Whenever a patient steps into a clinic about hypertension management, there are 5 things that you need to remember. First thing is you must establish the BP control, not just the clinic blood pressure, the home blood pressure. If they have home recording of blood pressure, it's best to review them. Assess the complication or the side effect of the medication. Many of these patients have side effect from the antihypertensive therapy, especially some of them can have pedal edema, some of them have cough. If they have side effects, the chances of them comply with medication is probably very low. At the same time, if the blood pressure is uncontrolled, you always should think about secondary cause of hypertension. And at the same time, you should ascertain target organ damage, for example, arteriosclerosis, stroke, or renal problem, for example, proteinuria and things like that. And finally, you assess the lifestyle and identify other cardiovascular risk factor which coexist with hypertension, for example, obstructive sleep apnea, which is very common and is very undiagnosed. Okay, this slide is probably you have seen this slide before. I think it's a very important slide because it shows the magnitude of how much blood pressure reduction can actually reduce cardiovascular risk. This slide actually shows that by reducing 2 mm mercury or 4 in the systolic blood pressure, you can actually reduce the stroke mortality by 10% and can reduce your cardiovascular disease risk, ischemic heart disease risk by 7%, which is I think is a powerful numbers to show it to your patient. At the same time, if your blood pressure is not controlled, every increase in your 20 mm mercury of systolic and 10 mm diastolic can double your cardiovascular risk. I think this is another powerful slide that you can actually show to the patient that blood pressure is actually very important. Now, this data is based on a registry from close to 240,000 patients. So ARB has the highest compliance rate in the real world study. Their side effect profiles are very low. They don't have as much cough as an ACE inhibitor, and they have more than enough evidence of its use in hypertension. When you look at this study, it actually show that more than 50% of the patient still comply with an ARB with the mean use of about 240 days, compared to the least comply, which is your diuretic. Okay, so again, this slide actually taken from another registry showing that the effect of discontinuation of antihypertensive medication have higher incidence of stroke and MI. This registry actually is close to about 77,000 patients. It shows that rapid or sudden discontinuation of hypertension actually increase your stroke and MI risk exponentially. So you should not suddenly remove the antihypertensive treatment when she is on. So besides the benefit of lowering the blood pressure, we know that ACE and ARB are useful drugs. They don't just reduce the blood pressure, they also decrease the risk of progressive kidney disease. They decrease the risk of dying if someone with very high risk cardiovascular disease, and it also decreases the exacerbation of heart failure. So stopping these drugs because of unknown potential side effect can have a detrimental effect for the patients. Now this is a summary of the historical trial that has been studied on ACE inhibitor on heart failure. Across the board, ACE inhibition has been reduced the mortality rate and reduced the hospitalization of patients with heart failure. Okay. Now, the clinical evidence suggests that this mechanism of action has benefits that go beyond blood pressure. The data are now emerging that ARB have cardiovascular, cerebral, and renal protection. This is in particular important for early and aggressive targeting of risk factor for cardiovascular disease. Again, another historical trial that shows that compare your ACE and ARB, and you can see that ARB reduce the mortality in patients with heart failure. At the same time, they reduce hospitalization. Okay, this is more like a practical sense. If you stop the patient from taking ACE and ARB, you need to change it to a new treatment. Changing to a new treatment means that you need to monitor them more. You need to see them more. With the era of the pandemic of coronavirus, social distancing is an issue. Of course, you wouldn't want them to come to your clinic more often than usual. At the same time, not just come to the clinic, they have to go to see the pharmacist and collect the medication. At the same time, lab investigation. So this is probably not a good idea when you have issue about cross-contamination and infection of coronavirus. So the key takeaway message for today is, number one, animal studies have shown that the use of ACE and ARB increase the level of ACE2. The concern arises due to the COVID-19 virus bind to an ACE2, therefore causing infection is there. Nonetheless, human studies have shown there's no correlation between the use of the ACE and ARB or the disease, what they call it, the disease manifestation, and the use of this medication have not shown to alter the cause of the infection. Hence, there's no sound scientific basis or evidence to support that ACE and ARB increase the risk of COVID-19 infection and severity. In fact, there is evidence from some studies in animals to suggest that this medication might be rather protective against lung complication in patients with COVID-19 infection. So the Council on Hypertension strongly recommends that physicians and the patients should continue the treatment with the usual antihypertensive therapy, because there's absolutely no clinical or scientific evidence to suggest that treatment of ACE and ARB should be discontinued because of coronavirus infection. Okay. With that, I end my presentation.
Thank you so much, Dr. Chu. We haven't received any question from our viewers as for now. So if you have any question for Dr. Chu, please do WhatsApp me at 014-6700-985 and we will get back to you as soon as possible. Dr. Chu, do you have any last advice for your viewers out there?
Last advice: social distancing. Okay. The pandemic, COVID-19 has changed the way we treat patients. It have changed the way how we manage patients. At the same time, it even changed the way we conduct our CME. So I think the solution is vaccine. Only when the vaccine is available, that probably all of us can go back to the normal before the pandemic.
All right. Thank you so much, Dr. Chu, for the updates. I believe our viewers out there receive a lot of useful information from you through this session. Thank you once again, Dr. Chu.
Thank you.
To our viewers, if you have any further question after this session, do not hesitate to send your question via WhatsApp to me at 014-6700-985, and I will try my best to get Dr. Chu to answer them. And also, we have another online CME session with our neurologist and physician, Dr. Chris, vestibular syndrome and targeted temperature management for post-cardiac arrest patient on next Friday, 10th of July at 5:30 p.m. Let me know if you are interested, and we will share the link for you to join. And also, don't forget to scan the QR code at the end of this live by using your MMA Doctor phone application to get your CPD point. If you have problem to scan the code, please do let me know. I will help you to enter your attendance manually into the system. With that, we have come to the end of our online CME today. Thank you and see you next time.